Hello and welcome back to the next section of your medical education. Today we passionately and intrusively enter into your bone marrow with hematology. And over the course of the next hour and 15 minutes we're going to do microcytic and macrocytic anemias. What could there be more basic, more straightforward? Now all anemia in general and without emia, blood. Emia, where's my emia? I've got no blood. Anemic, without blood. Now, all forms of anemia, no matter what the etiology is, has the same presentation based on how low the hematocrit is. It's not the etiology, it's based on the severity. It's not the etiology, it's based on the severity. In other words, if you have iron deficiency with a hematocrit of 28, you can have the same symptoms as thalassemia with a hematocrit of 28 as the same symptoms as sideroblastic with a hematocrit of 28. It's not the etiology, it's based on the severity. It's not the etiology, it's based on the severity. So all forms of anemia, their symptoms is based on the hematocrit. Now, a normal hematocrit for men and women, the hematocrit and the hemoglobin, the normal hematocrit and hemoglobin is based on a ratio of about 1 to 3, meaning that if your hemoglobin is going to be 14, then your hematocrit is going to be about 3 times that amount, which is 28, 38, 42, and a normal hematocrit hemoglobin, if you want to say 14 and 42, if you want to say 15 and 45, if you're used to working in hemoglobins, multiply it by 3 for hematocrits. If you're used to working in hematocrits, divide by 3 to get the hemoglobin. Whichever one floats your boat, it doesn't really matter. I haven't really found any difference. So when the hematocrit, which normally should be at a rate of 37 or 38 for women and 40 or 45 for men, because women menstruate, so they're slightly lower. When the hematocrit is above 30 or 35, the patient should complain of nothing. What, me? I'm anemic? I didn't know I was anemic. I'm anemic? I didn't know that. How'd that happen? I didn't know how'd I get anemic? I didn't know I was anemic. Now, when the hematocrit goes a little bit lower and you're down at 25 to 30, people start to feel tired. They start to feel fatigued. They get worn out. I'm out of gas. I feel tired. I feel fatigued. Oh, I'm out of gas. Particularly after exertion. Now, when the hematocrit starts to go lower than that, people start to get short of breath. Particularly on exertion. They walk and their blood cells just can't carry enough oxygen to the tissues. So they start to become dyspneic and short of breath because they can't get enough oxygen carrying capacity out to the peripheral tissues. So people who have moderate forms of anemia start to feel more short of breath. So we start to feel short of breath, we start to get dyspnea, we feel tired, we feel fatigued, we feel dyspneic. Now under 15 or 20, under here, depends on who you are. You start to get short of breath, you might start to get confused. You might start to get lightheaded, confused, short of breath, and ultimately, how do you catch death with anemia? How do you die? Now, when you ask this question to people who usually are in a live class, they go, well, anemia. Yeah, but how do you die? Well, you can die, right? Well, which organ is it that gets hypoperfused with oxygen that you can't live without? Which one? The answer is a myocardial infarction. You start to get ischemia. And the reason that you get ischemia is because the left ventricle cannot distinguish between a stenosis in the left anterior descending artery versus stenosis in the left main coronary versus anemia. If you're a myocyte in the left ventricle, all you know is you're not getting enough oxygen. Why aren't I getting enough oxygen? Hey, would you send me a little oxygen? What's the guy got to do to get some oxygen around here? Where's the oxygen? Is it a stenosis? Is it carbon monoxide poisoning? Is it low cardiac output or low saturation? Or is it just a low hematocrit? If you're a myocyte in the left ventricle and you're not getting enough oxygen, all of these things, ischemic heart disease and coronary disease, anemia, low saturation, or carbon monoxide poisoning, which has a fully saturated hemoglobin but won't release it to the tissues, all of these things feel the same to you. Now, you might say, for those of you out there trying to figure out which one did he say, which one was the shortness of breath? Was it that one, or which one was the? Now, you might think I'm a random guy. That, well, you know, I'm just sloppy. Well, yeah, I am sometimes, but not about this. This is done purposely this way. Because if you're a 38-year-old healthy guy, 23-year-old healthy female, you're not going to even feel a hematocrit at 28 and 29. Pregnant women routinely have hematocrits in the 20s, and it's not horrible. However, if you take that same hematocrit that would occur in a pregnant woman and you put it in a 72-year-old man, that guy's going to infarct and die because he needs more oxygen carrying capacity. You're not even going to feel it in a younger person, whereas an older person, in fact, might die because their coronary arteries are stenosed. Therefore, the young and healthy person feels it not very much, but the older sick person will feel it to the point of dying. So therefore, these symptoms overlap based on the underlying health of the organism, which is to say, are you young and healthy? You won't feel this. Old and sick, you're going to feel it big time. How do you die? Ischemia. So we break down the anemias according to the MCV, the mean corpuscular volume. Not reticulocyte count, not that automatically, but MCV. Because when you have high MCV anemias, low MCV anemias, and normal MCV anemias, it helps divide these up in our brain. That ends up being very useful for our psychological organization. High MCV anemias is B12 and folate deficiency. But in addition to B12 and folate deficiency, we also have things like liver disease and alcohol and various drugs that can cause you to have a macrocytic anemia. So there are various drugs that cause a macrocytosis that are not from B12 and folate. Now, what's the difference between a macrocytic anemia and megaloblastic? The difference between a macrocytic anemia and megaloblastic, macrocytic just means large cells. Megaloblastic means hypersegmented neutrophils, hypersegmented polys. I've more than 4 lobes. I'm feeling hypersegmented today. Hypersegmented neutrophils, more than the average lobe count of 3.5. An average above 4, you're hypersegmented. Greater than 5% above 5 lobes, you're hypersegmented. 1 6-lobed neutrophil means that you have megaloblastic anemia. Now, the difference between megaloblastic and macrocytic is that megaloblastic just means a large volume, but hypersegmented means that you have more lobes in those nuclei. These are megaloblastic, these are macrocytic, all of them, but only B12 and folate is megaloblastic. Low MCV anemias is iron deficiency, is anemia of chronic disease, is thalassemia, and is sideroblastic anemia. Low MCV anemia is sideroblastic, anemia of chronic disease, thalassemia. Now, the anemia of chronic disease can be both microcytic and normocytic. It can be both of them. However, the anemia of chronic disease fits in more neatly with microcytic anemias because it is a person who has low production of cells the majority of the time. So the low production of the cells here it's giving a low reticulocyte count, fits in better with these production disorders. Because the normal MCV anemia is basically iron through blood loss and hemolysis. So blood loss and hemolysis are the two best ways to get a normal MCV anemia. The reason that the mean corpuscular volume is normal is that if you bled out a pint or 2 pints, 2 liters of blood from your rectum today, your bone marrow does not have the time to change the size of the cells that are being produced. In other words, things that cause normal MCV anemias tend to be acute. And the two acute ways to lower the hematocrit is blood loss, bleeding, and hemolysis. These are the two main things. And the reason that this fits together better is that these things have low reticulocyte counts, these things have low reticulocyte counts, and these have high reticulocyte counts. Low reticulocytes for both of these, high for this one. That's why we put chronic anemia here, chronic disease. The anemia of chronic disease fits in better with this production problem. Hemolysis and loss, the reticulocyte goes up because the bone marrow is trying to compensate by increasing the level of production of the new red blood cells. All right, microcytic, macrocytic, normocytic.